Good morning, everyone. I'd like to call to order this hearing of the Health, Finance, and Policy Committee. Appreciate everyone being here after those of us, the members and the staff, had a really late night. And here we are again, trying to get done before deadline. So appreciate everyone's attendance. So we're going to start. Representative Elkins, do you have a motion for approval of the minutes?
I do. So moved, Madam Chair.
All right, thank you. So moving approval of the minutes of April 9th that are in your packets. Is there any discussion to the minutes? Seeing none, all in favor of approval, please say aye.
Aye.
Opposed? Motion prevails and the minutes are approved. Representative Curran isn't here yet, so we're going to start with House File 4779, Representative Hicks. And since Representative Hicks is not on the committee, I will move that House File 4779 be laid over for possible inclusion. And with that, and there is an A1, but we will wait on the A1. We'll present the bill and speak to the bill and then do the A1 a little bit later. So Representative Hicks, welcome to your bill.
Thank you, Chair. Thank you, committee members. Some of you serve on other committees with me, so you're well aware that children's mental health is a primary concern.
And Representative Hicks, could you just pull the mic up a little?
How's that?
Much better, thank you.
I forget that this room has picky microphones.
We need a new building, don't we?
This bill establishes a medical assistance benefit for children's residential mental health crisis stabilization services. The goal of these services is to better support children and families by providing the appropriate level of care in a community setting earlier in crisis. This helps prevent potential need for children in hospital emergency rooms and more invasive and expensive residential programs, which, as we heard in Human Services Policy, many times are out of state. The children's mental health crisis continues to be a significant concern in Minnesota. We know that we are short hundreds of PRFT beds. We are short outpatient providers. We are short skill providers. Our children cannot access the care they need when they need it, and they may end up in crisis. In our community, the Southeastern Regional Crisis Center, or CIRC, has been providing these services for children and youth in the region since 2021. CIRC also provides community-based residential stabilization services for adults, but these services are already covered under medical assistance. We know that our counties and providers across the state would also like to see these services be available to children and families in their communities, but the current funding model is not sustainable. Coverage through medical assistance will help ensure that children's crisis stabilization services can expand statewide to better support our children and families. That is the purpose of 4779, and I'm happy to have a testifier from our community to talk a little bit about that, and would love to invite them to join us.
All right, thank you very much, Representative Hicks. So we'll have the testifier come up. Welcome to the committee. Please introduce yourself for the record and go ahead and give your testimony.
Good morning, Chair Liebling and committee members. My name is Travis Granzi, and I'm a Olmsted County Deputy Administrator overseeing Health, Housing, and Human Services. And today I'm here testifying on behalf of Olmsted County, the Minnesota Intercounty Association, the Association of Minnesota Counties, and the Minnesota Association of County Social Service Administrators. So thank you, Madam Chair, for the opportunity to express our strong support for House File 4779. We're also grateful for Representative Hicks for authoring this legislation. House File 4779 establishes a medical assistance benefit for children's residential mental health crisis stabilization services. Many children and youth in our community across the state face difficult mental health and behavioral health symptoms each day. The current service delivery landscape, as Representative Hicks described, doesn't offer adequate community-based solutions to address the needs of many of these families. Olmsted County is proud of our local partnerships and grateful for the strong support from the Minnesota legislature that enabled us to build and operate the Southeast Regional Crisis Center. Through the CIRC, the county and local partners provide walk-in mental health services 24 hours a day, 7 days a week, including community-based residential stabilization services for children, youth, and adults. The residential stabilization services provided for adults at the CIRC are funded through medical assistance, but the same services for individuals under the age of 18 are not covered. Residential crisis stabilization services are critical for children and youth to access services needed to resolve a crisis episode. This supports families by working with individuals experiencing mental health symptoms in a community setting. The goal is to reduce more costly services such as emergency departments and child placements, as well as providing connection to ongoing services needed to prevent future episodes. Counties also support another bill on your agenda today, House File 3495, which has similar language to establish the medical assistance coverage for children's residential stabilization services. We don't have strong preferences regarding the language, but do prefer the timeline that's outlined in our bill to establish the coverage more urgently. So thank you, Madam Chair and members, for your consideration of House File 4779.
All right, thank you, Mr. Granzi. Is there anyone else who wants to testify on the bill? All right, I'm not seeing anyone else. And just backing up a little bit, I never announced that there is indeed a quorum present, so that is kind of important. Anyway, that being the close of testimony, is there any discussion to the bill? This questions. Representative Brindley.
Thank you, Madam Chair. I assume a fiscal note has been requested for this.
Would you like to hear about that? Because we do have one.
Oh, it already exists.
Oh, yeah. I'm sorry. I'm confusing it with a different one. Right, Mr. Harney.
You're like, wait.
It is kind of fog. It is a fog this morning.
Madam Chair, Representative Brindley, there's a fiscal note requested for the underlying bill and the author's amendment that hasn't been adopted yet. The testifier mentioned similar language in the Fischer bill that's on the agenda today that we do have a cost estimate for, but not a complete fiscal note on yet. So we're waiting that information.
Representative Brindley.
Thank you, Madam Chair. And perhaps Mr. Harney can also explain, looking at this does not go into effect until January 2026. So how would that be accounted for as far as our budget cycles go?
Mr. Harney.
Madam Chair, that would be in the middle of, be the beginning of plan year 26, in the middle of fiscal year 26. So I would assume a forthcoming fiscal note would show an impact half in the next half in fiscal year 26 and the full effect in fiscal year 27 for the added benefit under medical assistance. But without a complete fiscal note, I can't say that for certain.
And Representative Brindley, so we are a little additional information from DHS kind of reminding us too, what this bill is doing is working on establishing a new rate. So until we have that preliminary work and understand what that rate would be, you really can't fiscal note it. So my understanding is that what we would have to do is, this is to do the preliminary work, and then it just comes back to us to see if we want to and can afford to actually do this. So that's kind of my understanding. Is Mr. Harney, do you?
Yeah, Madam Chair, I believe you may be confusing the language in the Fischer bill with the language in this bill. So Section 1 of this bill, Subdivision 72, adds an effective date of January 1st, 26, or upon federal approval, whichever is later, for medical assistance coverage for residential crisis stabilization grants. So this bill does establish the pursuit of a benefit upon federal approval.
Yeah.
The Fischer bill and the amendment, after the amendment for the Fischer bill is adopted, doesn't.
Okay. Well, that makes it a little clearer. So Representative Brindley, so obviously our intention is if we carry this in the omnibus, we're going to have to fit it into the budget. So we'll have to have it in a form in which we can do that. But I think at this point, we're not really going to be able to know and commit to the rate when we don't yet have any idea what that's going to be.
Thank you,
Representative New Brindley.
Thank you, Madam Chair. That was a perfect comment, and it probably leads us to understand that this probably isn't feasible for this session because we won't even really have a good handle of the costs. Thanks, Madam Chair.
Well, thank you. And actually, let me just comment a little further on that. So sort of my intention is to get this process started. So I do intend to have a form of this in the omnibus bill because we want to get started on figuring out what this rate should be. We may not be able to commit to implementing it in the future because of our fiscal situation. We don't have a big tails target to do that. But we definitely want to get started because if we don't get started figuring it out, we're not going to ever be able to do it. So that's kind of the intention here. And so there are different versions of this bill, so it is a little confusing, but we'll get it figured out. Representative Bahner.
Yes, thank you, Madam Chair. Representative Hicks. It seems to me this bill, does both implementation and studying at the same time. So to me, that's not usual, but mostly you study first and then you implement. Tell me the reasoning behind we're, in essence, doing it, from what I could tell, the same time simultaneously.
Yeah, so.
Representative Hicks.
Thank you, Chair. So we actually have, we have the CERC in Rochester, and I would invite any of you who want to come down to Rochester to come see it. At the CERC, you can stay for up to 10 days when you're in a crisis and get some stabilization. You get therapy while you're there, and it gives your family time to align other services. It gives the county, if there's a need for county support, to start working with the family to identify other supports and other services. So we do have an active model that's working. And we do provide medical assistance payment for adults. We just don't do it for children. But we also, one of the things that is really hard in this body is we cannot quantify a negative, right? So I can tell you that it reduces hospitalizations, but if the person never goes to the hospital because they're stabilized at the CERC, there's not a data point for me to be like, see, it saved $15,000, right? Because it's hard to quantify a negative. But by really taking a look at it, I believe we can. Because if a child spends 10 days at the CERC and it is cheaper than 72 days boarding in an emergency room where they don't see the light for 2.5 months while we try to find an appropriate placement, it is better for the child, it is better for the family, it is better for our community, and it's better for our bottom line. So the reason we're doing it simultaneously is because children cannot wait for us to study their crisis for 3 more years. We don't have time. We have children in this state who have been living in emergency rooms for an entire year of their life. 2 years. We don't have time to study it and then implement it. We already know this works. We have a model. You're welcome to come. I'll take you all. Travis, can they come?
Yes.
They can come. And you can see how amazing this is to work. But I have no intention of being the one who says children have to wait 3 more years for us to work to solve this crisis.
Representative Bahner.
Yeah, thank you. And thank you, Representative Hicks. So the bill, though, does talk about studying, so I get your perspective there. So what are you going to be studying? It seems from what you're sharing with us, Representative Hicks, you're pretty already have your mind made up of what needs to be implemented. So to me, and I mean this professionally, it's kind of a smokescreen that we're studying. What are you studying? Help me understand that. Help us understand that, please. And I'm not here to let you up, Representative Hicks.
Oh, no, you're good.
Representative Hicks.
Thank you. And I know that. I'm just really passionate about this because I'm really, devastated for the children and families that are stuck with no solutions because we can't act. The purpose of the study piece is to identify, one, like I said, the return on investment, right? Being able to really say this works. Here's why it works. What are the pieces that work? The other piece is that whenever we're adding a new Medicaid service and whenever we're going to the feds and saying, we're going to try this thing, we're going to do this, sometimes we need to tweak it. And if we don't have a report and we don't have a way to sort of identify where we can make changes, it's really hard to do that. The other piece is that the way we're doing it at CERC is working really well for us right now in this moment. But like all things, we probably have spaces where we can do better. I don't know what those are yet, but I think that if we can fund this service and we can take a look at the outcomes, we can figure out what they are, right? Maybe it's that we add family therapy as part of crisis stabilization. I don't know. Maybe it's that we change the days. Maybe it's not 10. Maybe it's 15. Maybe it's 5. I'm not sure. And we won't know until we make it a Medicaid service where we can really dive in and look at that. And I think this is an opportunity to start that process. As Representative New Brindley pointed out, it is longer than I would like it to be as it stands. But I don't think that it makes sense to wait any longer and say we need to know the perfect to get to good. So I'd like to start with good and work towards perfect.
Representative Backer?
No further questions. Thank you, Madam Chair.
All right, thank you. Mr. Granzi, did you want to add anything? You don't feel compelled, but.
Thank you, Chair Liebling. Maybe one thing to add is that, the current funding model, the services for the youth that are at the CERC and facilities like that across the state, then the bills right now come to the counties, and that's not my point. My point is that when we have a system that's set up like that, and that the responsibility then falls to the county, and the county has some input into the authority in regards to whether or not a child ends up in a placement like this, sometimes counties with less resources then will make decisions based on whether or not a child is placed, based on the money and not on the need of that child. And I think this really, the introduction of this bill and this idea really reduces that too, so that we make sure that the kids that need the service get the service, and it doesn't become a decision in regards to whether or not the county has the resources to make that service happen. So I also think that's an important consideration for this bill. So thank you.
All right, well, thank you, Mr. Granzi, thank you. So we will go now to the amendments. So Mr. Granzi, if you would like to go, you can sit back there. And so I will move the A1 amendment, and this amendment is Representative Hicks, if you would want to go ahead and explain the A1 amendment.
Yes, thank you, Chair Liebling. Like my testifier shared, in the current system, we're putting all of the weight on our counties, and by moving to a CPT code or moving to a Medicaid service in Medicaid for crisis stabilization, we divide that cost up amongst federal and state dollars. The amendment takes a look at how do we do that for other services in related to CPT codes. So for those of you that are not fascinated by medical billing, CPT codes are the general codes for service billing. And in Minnesota, many of our children's mental health services use H codes. H codes are not used by commercial insurance. So on the Medicaid side, we use H codes for CTSS. And on the commercial side, we use CPT codes. And what that has done is it's created a difficult situation for our providers to create a benefit that can serve both populations. And that's not great for a variety of reasons for kids and for families, but it's also not great for taxpayers. Because if the service that's been created is only does Medicaid, then commercial payers can't access that service, and so people's only option to get the service for their kids is to get them on Medicaid, putting the burden onto taxpayers. And so the amendment asks the department to take a look at that. Are there CPT codes we could be using? Is there a different way to do this to help with the methodology, make it simpler, make it easier for commercials and Medicaid to work together, and easier on our providers so we can serve more kids regardless of how they're insured?
All right, well, thank you very much for that, Representative Hicks. Is there anybody who wanted to testify on the amendment?
I have a provider.
Okay. Oh, please come down. All right, welcome to the committee. Please state your name for the record and go ahead and give us your testimony.
Shannon Brown. Good morning, Madam Chair and members of the committee. Thank you for the opportunity to testify in support of the A1 amendment. My name is Shannon Brown, and I'm the CEO of Fernbrook Family Center. Fernbrook provides a variety of mental health services across 9 counties in southeast Minnesota. My testimony is on behalf of the voices of many of those providers. This amendment would direct the Commissioner to convert billing codes for children's therapeutic services and supports, otherwise known as CTSS, which are currently billed through the Healthcare Common Procedure Coding System that Representative Hicks spoke to being billed under CPT codes. CTSS codes include things like individual, family, group skills training, Children's Day treatment, treatment planning and development, and a few others. CTSS is designed to provide additional supports to kids whose mental health symptoms are severe enough that psychotherapy alone will not be enough to improve their functioning. CTSS codes allow us to provide more intensive services multiple times a week and provide opportunities for the kids and families to practice the skills they're learning in therapy to ensure mastery and create stability more quickly. Many of the clients we serve in our CTSS program have experienced significant neglect, physical and sexual abuse, changes in caregivers, unpredictable caregivers, among many other things. By providing a more intense level of care with more hours of service, we're able to make progress more quickly and are able to teach skills in the moment while the child is experiencing distress. Many children learn best with repetition and practice and opportunities to practice the things they're learning. And that is exactly what CTSS allows us to do. We create opportunities for repetition and practice of skills. Adjusting the CTSS codes to CPT codes would open an opportunity for commercial insurance companies to cover these services. Currently, very few, if any, commercial insurance companies cover any CTSS services. This often delays or can prevent access to needed care and ultimately places the burden to cover intensive mental health services on Medicaid payers, grants, and the family. Billing these codes under the current system is also an administrative burden for billing teams responsible for sending billing lines to insurance companies. The system is complex and requires many modifiers and additional steps. There are often rejections or additional steps required in order for agencies to receive reimbursement. CPT codes typically are much easier to bill with fewer, if any, modifiers and adjustments needed. Moving these codes to CPT codes continues to move towards a sustainable reimbursement system that enables providers to continue to provide the services that are vital to the overall well-being of Minnesotans. Thank you for your leadership and support.
Thank you. Thank you very much. Is there anyone else who wants to testify on the amendment? All right, not seeing anyone, so we'll go to discussion on the amendment. Is there discussion? All right, not seeing any, so we will then, I will then renew my motion to adopt the A1 amendment. All in favor of adoption of the A1 amendment, please say aye.
Aye.
Opposed? No. The motion prevails. The amendment is adopted. And so with that, Representative Hicks, any final words on House File 4779 as amended?
Thank you, Chair and Committee. Children's mental health is complicated. It doesn't exist in a silo. It's not only in health. It exists across our spectrum. When children with mental health needs do not get those needs met, they end up in other parts of the system, whether that be more expensive residential statements, whether that be in 260C or D in involuntary out-of-home placement, whether that be in a juvenile justice facility, or whether that be out of state. When we do not address children's mental health as an entire continuum, we fail our children. There are many bills this session, and there will be bills in the future, and there were bills in the past. There's not one solution, but this is part of that solution, and it moves us in the direction of truly supporting our children. So I appreciate your time and consideration today.
All right, thank you very much, Representative Hicks. So with that, House File 4779 as amended is laid over for possible inclusion. Okay, Representative Curran is here, and while Representative Curran is coming up, I would just say thank you to Representative Hemmingson-Yager for the treats this morning. I'm sure she knows that we all are in a fog, and it's a great morning for that. Thank you very much.
And they're amazing.
Yes, a little bit.
Yeah, and I don't know, where are they? Are there more?
There's two over here.
They're around.
They were still warm, so get them quick.
Okay, all right. All right.
Lot of the.
Yeah, bill authors as well, of course. All right, well, Representative Curran, welcome to the committee. The chair will move House File 4713 and to be laid over for possible inclusion. And maybe we should, well, why don't you go ahead and present the bill, and then we'll talk a little bit about the procedural issue here.
All right, fair enough. Thank you so much, Chair and committee members, for your time this morning.
So House File 4713 is a bill in direct response to compliance issues with Water Gremlin and the blood lead levels of its employees. Water Gremlin was a manufacturer of battery terminals and lead fishing weights in my district. Water Gremlin has since gone out of business, but the effects are unfortunately lasting and devastating. This bill would lower the acceptable blood lead levels of employees. In 2017, the elevated blood lead levels of employees' children surfaced, but no laws since have changed. Children of workers considered to be within the acceptable range of blood lead levels suffer from impairment as a result of lead exposure. Currently, Minnesota's OSHA standards say an employee must be removed when their blood lead level reaches 50 units, and they can return to work when that level reaches below 40. However, the CDC states that even 5 units can lead to decreased renal function, and a blood lead level of 10 units is associated with increased blood pressure and hypertension. There's no safe blood concentration. However, this legislation will work to create a new acceptable level based on current data on the effects of lead. I did intend to include a letter from a local group called the Neighborhood Concerned Citizens Group. Not sure if that made it into members' packets yet today, but just briefly, this was a group that was formed specifically in response to Water Gremlin's effects on my community, not just through worker exposure, but initially through contamination in the nearby neighborhoods. When earlier concerns were raised due to the environmental contamination, workers began to come forward to offer their experiences bringing lead into their homes. Various pieces of legislation in the past have addressed several issues, including addressing TCE, which is a major component of this facility. We've uncovered a number of issues affecting community members near the Water Gremlin facility. Now we're specifically addressing concerns with worker exposure and the effects on those employees and their families. We know this important work in the state legislature often comes directly from our community members, and this bill is a result of my community's diligence and continued efforts. This bill has had a couple of hearings in the Senate side. Just a couple things to note. We did have a testifier in the Senate who was an employee of Water Gremlin for over 25 years and unknowingly migrated lead into his home on his clothes. He also noted that coworkers had left seemingly to go on vacation, only to find out that folks had never returned, and at least one case had passed away. When trying to advocate for change, this employee was not only met with challenges in the system, but with physical threats of violence from management at the company. To be fair, I'll also note that there was some oppositional testimony in the Senate, and as you might expect, that was from Battery Council International, who does battery manufacturing. They agreed with the general concept, but they believe this is not the right approach, and I'm continuing forward with this bill because I believe that we do have an urgency to move forward on this. I'll note that federal level OSHA, our federal level OSHA is analyzing standards for rulemaking. Until that is done, opponents of this bill think that a Minnesota standard might create some confusion. I feel and others feel that there is still plenty of room for Minnesota to make a decision on where we stand on acceptable blood lead levels, and that if and when the federal government does decide what that level is, Minnesota hopefully would be in a position where our acceptable level is already lower than what the federal government decides. So I know that that has been a concern that's come up in prior committee hearings that I've heard, about the length of time that this could take, and what if the federal government comes up with its own standard. And my response to that is, we've been waiting and waiting. Other states that have tried to pass this have waited over 10 years in some cases. And in my community, it's already too late to be doing this work. So that's why I'm eager to push this forward. And I am happy to answer any questions.
All right, thank you very much. Well, let me just first ask if there's anyone in the room who wants to testify on the bill. Okay, not seeing anyone, we can have some discussion. I just would want to say that this bill is actually, my understanding is the language will be carried by Labor, and the Labor Committee is carrying the first biennial cost, and then we're going to carry the very small tails cost. So that's why it's here, because we're going to carry the very small tails cost on this bill. And I just would say, too, before I go to Representative New Brindley, that this committee, as the Health Committee, knows a lot about lead, right? And we know that there is no safe level of lead, right? That has been drummed into us, right? So anything we can do to reduce lead, and we can leave the labor issues could stay in the Labor Committee, but we're concerned here about the health impacts of lead. So Representative New Brindley.
Thank you, Madam Chair. Is there any indication with, and you had mentioned that OSHA is working on the standards. Is there any indication of where they are in that process and how long or short that process is going to be at this point?
Representative Curran.
Thank you, Chair, and thank you, Representative New Brindley. I think that's sort of the point why we're here, right, is we know that they are working on it, but there is no definite timeline. And so that, that's concerning to me. I don't have an estimate of when that might be done. But as I mentioned, other states, when they have, other states have tried to do this too, and in some cases have tried to wait for the federal standard, tried to push for this legislation. There are a couple of states who were successful in getting this done right away. And so I'm hoping that Minnesota can become among those leaders who've stepped up to the plate to do something about it at the state level. It's really hard to say when something at the federal level might get done.
Representative New Brindley.
Thank you. Thank you, Madam Chair, and thank you, Representative Curran. So interestingly, and I understand that obviously government works slowly, but sometimes there's reason for that. I'm a little bit concerned in the language that there is virtually no direction for the commissioners in developing this rulemaking. It literally just tells them to make a rule on two things with no additional direction. And I'm a little bit concerned that we're giving really, really broad authority to these two commissioners without any real parameters on what specifically they should be looking at, what they specifically should be taking into consideration, and just telling them, make rules on these two things. And perhaps this has taken some time in other states because it's actually complicated. And so it seems a little maybe not the best idea for us as legislators to just give this authority without parameters. This is how things are done quickly, and I've talked a lot in this legislature. Sometimes when we do things fast, we do them wrong. And so I'm a little concerned that we are asking commissioners to do this fast with very little direction, and that's how we get things wrong. So thank you, Madam Chair.
Okay, Representative Curran, why don't we do this? If you would kind of make note of your responses, and I'm going to go to we'll finish getting the questions out, and then I'll have you wrap up. That will work. Representative Murphy.
Thank you, Madam Chair. Thank you, Representative Curran. My question is just about the lawsuits. Do we have any actions from them or information that you can share? I think there looks like there's 95 lawsuits against the company.
Okay. All right. Well, that's a pretty specific question. So if you want to answer that and, go ahead and make a statement, and we'll see if Representative Murphy has a follow-up.
Sure. Thank you, Chair. Thank you, Representative Murphy. I don't know where each of those cases stand today, but you're right. There were at least 95 cases brought against Water Gremlin. I do know that the closure of Water Gremlin, I know that their assets were greater than their liability at the time, and so I believe that part of their closure was intentional so that they would have enough assets to cover what these lawsuits might bring for them. And so I know that they very well anticipated having to pay out for these lawsuits, if that helps answer your question.
All right, any follow-up?
Just one follow-up. Who do you think will be responsible to pay that since they're in bankruptcy?
Representative Curran.
That will be for Water Gremlin and their legal team to decide. I know that unfortunately in our system, we can say that folks might be on the hook to pay people at the end of a court case, and sometimes the liable party is not able to shore that up right away, and that's really unfortunate. And so I'm hoping that with this bill, we can save folks from having to bring suits like this in the future, and then, facing the potential of not getting anything in return.
Thank you.
Thank you. Okay, I don't see any other questions, so, again, this is the Health Committee, so, some of these legal issues might be a little bit outside, but anyway, thank you for bringing the bill. Representative Curran, do you have a final word for us?
Yeah, I will just say I understand the concerns about a bill that, quite frankly, if you look at the bill language, it is really short, right? And I think that is intentional, and it's not so that this is widespread authority that's vague. This is so that we have the ability to gather all of the appropriate information from the necessary sources. I'd hate to cite a single scientific source and then find out that there are others out there who are able to contribute to this information that could be crucial for this process. I believe that the integrity of the folks involved in this will be I believe in the integrity of the folks involved in this, and that their thought process will be taken seriously and centered around the safety of Minnesotans. And I'll just add that it's simply supposed to be based on the most recent public health information, and that's all we're looking for.
All right, well, thank you very much. So with that, House File 4713 is laid over for possible inclusion.
Thank you.
Thank you. Okay, now we will go to, so I see that Representative is here. We're going to do Bahner next. Yeah. Okay, House File 3902, Representative Bahner. And Representative Bahner's motion is that House File 3902 be laid over for possible inclusion. And Representative Bahner, to your bill.
Thank you, Madam Chair and members. Glad to be with you here today. We will dive right in. House File 3902, medical assistance or Medicaid professional dispensing fee reimbursement is straightforward. It updates the MA fee for service prescription dispensing reimbursement to more closely align with the actual cost of dispensing medication. Minnesota Medical Assistance is the health insurance payer for nearly 1.5 million Minnesotans. That amounts to about 26% of the population. Minnesota pharmacies are reimbursed for dispensing medications to the population in two ways. First, 80 to 85% of patients' medication claims are adjudicated and reimbursed through the MA contracted managed care organizations and their pharmacy benefit managers. The second way they get paid for the remaining 15 to 20% of the MA claims are reimbursed through the MA fee for service program. This bill would increase the MA fee for service rate from the current $10.77 to $11.55 in line with the most recent cost of dispensing survey to assess the fair rate of reimbursement. Under current law, the state of Minnesota, and specifically DHS, is required to perform a pharmacy cost of dispensing survey and make recommendations on the appropriate dispensing fee based on actual costs incurred by local pharmacies. The last increase for the MA pharmacy dispensing rate was 2018, based on 2017 cost of dispensing survey, meaning current rates for dispensing are based on data and cost to dispense medications 6 years ago. I think we all know that the cost of doing business has increased for all businesses during this time. The most recent cost of dispensing survey was completed last August, and looking at data from 2021, it included data for 90% of licensed pharmacies across Minnesota. Not surprisingly, The updated 2023 DHS cost of dispensing survey found that the cost of dispensing has in fact gone up, and the number of local pharmacies that continue to survive to participate in the survey has unfortunately dwindled. Based on the results, DHS has recommended revising the current professional dispensing fee from $10.77 to $11.55 for all community retail pharmacies. So let's get down to brass tacks. Why does the study matter, and why do the dispensing fees matter? MA serves as the largest insurer or payer in the state, making it essential to adequately reimburse pharmacies for the patient medications and health services that they provide. The fee-for-service dispensing fee is one of the only reimbursement rates that falls under the direct control of state government and plays a direct role in the outpatient pharmacy reimbursement rate and ultimately their survival. The reality is, if professional dispensing fees are not updated over time as intended, these same pharmacies may no longer exist to serve Medicaid patients or medical assistance patients. House File 3902 is one piece of the reimbursement equation and part of the broader conversation about sustainable pharmacy reimbursement. But this legislation takes a critical first step to keep Minnesota pharmacies strong, ensure they can continue to serve our communities. And with that, I will turn it over to you, Madam Chair.
All right, thank you very much. Welcome to the committee. Please introduce yourself and go ahead and give us your testimony.
Yeah, thank you, Chair Liebling, and good morning, committee. I appreciate you hearing this bill and the opportunity to testify today. My name is John Hessian. I'm a proud owner of St. Paul Corner Drug, where I've practiced as a community pharmacist for the last 35 years. I'm here to express my strong support for House File 3902, a crucial piece of legislation that will provide immediate and much-needed financial assistance to Minnesota pharmacies that serve rural and underserved metro communities, those of our neighbors who are most vulnerable to facing health disparities. Over the past 10 years, we have seen more pharmacy closures in Minnesota than any other state in the nation. From 18 to 23, 35% of Minnesota community pharmacies have permanently closed, and there are more on the horizon. We had 24 just last year, 4 this year, and more to come. Not one of these closure sites has a pharmacy today. The evidence shows that once they're gone, they're gone. So we absolutely need this increase now. To be clear, the fee-for-service dispensing fee of $10.77 that we are currently being paid was calculated in 2018 using 2017 cost of dispensing data. That was 7 years ago. The proposed fee increase of $11.55 was calculated in 23 using 2021 data, which will be 4 years in the past when implemented. This updated dispensing fee does not take into consideration any of the inflationary pressures we are all experiencing: cost of goods, insurance rate hikes, new regulatory mandates, and payroll increases. It's the least that can be done to get us closer to financial reality. Being the single largest payer of pharmacy services in the state, we feel compelled to ask that pharmacies be paid what they are rightly deserved for the services they provide residents of Minnesota, so they can continue delivering safe, efficient, and compassionate care to the patients as they have for decades. Dealing with the problems that arise when pharmacies are not adequately reimbursed for services they provide leaves pharmacy staff focused on survival strategies instead of patient care. For example, at this very moment I'm testifying, community pharmacists across the state are being forced to selectively decide to fill or not fill certain prescriptions for patients due to the fact that if they continue to fill these selected medications at $20, $30, $50, $75, and in many cases greater than $100 below cost per prescription, they will be forced to permanently close, leaving their communities with no access to pharmacy or other healthcare services. The ultimate decision we grapple with every day is, do we fulfill all the needs of our patients, or do we fulfill most of the needs of our patients? I'm here to tell you that fulfilling all the needs of our patients will surely end in our pharmacies closing, resulting in us meeting none of their needs. This is an unacceptable way to deliver pharmacy and healthcare services, and the residents of Minnesota deserve better. I just want to mention that I'm here. Buck was going to testify as well, but he's not going to at this time. So I'm here representing Minnesota Pharmacy Alliance, which is Minnesota Pharmacists Association, the Minnesota retailers, and the chain drug stores, and then also the College of Pharmacy. So thank you.
Thank you, Mr. Hessian. Thanks for all of your advocacy for pharmacy Really appreciate that. Is there anyone else who wants to testify on the bill? All right, not seeing anyone. So with that, we can go to discussion. Representative Nadeau.
Thank you, Madam Chair, and thank you, Representative Bahner, for bringing this bill. It's an important bill. I have a question before a comment, and it's for Mr. Hession. Thank you. So you talked about, and we know that pharmacies are closing across the state. How does our pharmacy mortality rate, I guess, compare with some other states? When you talk about, having to provide prescriptions at $100, $200 below cost. I mean, I'm looking at the fiscal note in this, and this is not even going to come close to making things more even. I mean, it's a help. I get it, and I think I support it. But what are the other things that we need? Just a high level. What are some of the other causes, and how are we comparing with Wisconsin, North and South Dakota? How is Minnesota different?
I'll let you answer. I was just going to say that's a big question, Representative Nadeau. There's a lot to unpack there, and I don't know if we want to put on Mr. Hession the whole weight of explaining the whole system and how dysfunctional it is. But anyway, if you can, Mr. Hession, please, if you can give any sort of brief answer, it'd be great.
Yeah, so what we're talking about today is as Representative Bahner had pointed out, is the 15% that is in the fee-for-service system of Medicaid in Minnesota. Another huge problem is the 85% that goes through the managed care organizations and the PBMs that they hire, who then underpay us, grossly underpay us for the services that we're providing. And so that is something, we intend to work on over the off session and hopefully bring something next year to get that more closely aligned with what the state is paying on the fee-for-service at cost plus the $11.55 if hopefully we get there. I know Iowa has passed a bill that I believe that makes the MCOs and the managed care organizations there pay that state statute rate. And so that would be a huge, huge win for Minnesota pharmacy. Is this the savior in this bill? No. But we know that moving forward, if we're going to get to a place where we get the managed care organizations and their PBMs to recognize that this is reasonable reimbursement, then we want this to be in the best place possible so that we can chase that. If we don't get this done, then the target gets moved. Yeah. And it just gets moved, the can gets kicked farther down the road. And I'm telling you right now, we don't have much time left.
Yeah.
Representative Nadeau.
Thank you, Madam Chair. And just my follow-up is last year we eliminated the copays for this population for pharmaceutical for prescriptions, and I don't recall. Was there a fiscal note? Will this fill that hole that was caused last year by eliminating copays, or was it not even close? I mean, was it just an infinitesimal number? Was there a fiscal note last year?
There certainly was, Representative Nadeau. We carried that cost, and I don't think the two things are related, but I don't know if maybe, I don't know, Mr. Harney, can you speak to that?
Madam Chair, Representative Nadeau, I don't have the number handy for the elimination of cost sharing for medical assistance passed in Chapter 70. You have the fiscal note in front of you for the cost of this bill. I can get back to you shortly with that net effect if you're curious.
Okay.
And let me just comment too on that question, Representative Nadeau. To my understanding, the problem too with charging out of pockets for people on MA is that the law already said that if they couldn't pay, you couldn't collect it. So a lot of times what that just did was create an additional hole for the merchant because they couldn't collect it anyway from the person. And not to mention an administrative burden to try to figure out, oh, now I've got to ask you for the $3 and that kind of thing. So maybe Mr. Hession can comment on that, but I think we maybe did them a favor by eliminating that and just paying for it. But Mr. Hession, do you want to comment?
That's exactly right, because there is no way when a patient cannot afford the copay and we don't collect it from them, there's no way of us going back and reprocessing that claim with a code that says patient couldn't afford copay, so we get the extra $3 reimbursement. We just give it up. It just comes out of the payment that we had received initially.
Follow-up, Representative Nadeau?
I mean, it's, I don't know, yes, and I thank you for that. I'm not all people on MA don't want to participate in paying for their health care. And some of them who can't, and I recognize that, and I think that's why we're here, to try to make sure that we do that. But I do think that there's impacts that we make here that are making it difficult for you out in the real world. And that's what I kind of want to work on. That's why I do appreciate this bill. I recognize that it doesn't go all the way. I'm worried about how we're going to pay for it, but I'm sure we'll get to that. And thank you, Madam Chair.
Madam Chair.
Thank you. Representative Bahner.
Very briefly, you are correct that this is one piece of the conversation, and I would highly encourage you to check out a few of my other bills that are more pieces of this conversation, including HF 503, that makes sure that pharmacists actually get paid for services that they deliver that are paid in any other setting except the pharmacy today. So there are many other pieces of this puzzle, certainly, and that point is very well taken. This is just one piece.
All right. Representative Breyer.
Thank you, Madam Chair. Thank you, Representative Bahner, for bringing this forward. As the daughter of a small pharmacist, a small business, I take this very much to heart and grew up knowing the relationships that my dad had with his customers and the valuable service that community pharmacies provide, whether they're in the city or in small towns. So thank you for your work. My question, and I'm sorry if I missed it, but I'm curious what the actual cost of dispensing is. What does it, if you were to say we were going to be whole on the cost of dispensing, what would we be looking at? What does it look like, the rate through commercial insurers? Could you just create a little more context? Thank you.
Yeah, so.
Mr. Heschen.
Thank you, Madam Chair. So the way the way the state has structured this, when they changed it in 2017, because there used to be, there's two parts to a prescription reimbursement. There's the cost of the product, and there's the professional dispensing fee, the overhead, if you want to call it, on a prescription. And so when they restructured it to more actual costs instead of this kind of calculated cost that had some product markup in it, when the dispensing fee was significantly lower, the two balanced each other, but there was just a lot of flux, and it wasn't, in a lot of prescription situation, it wasn't actually reflecting true cost. So this much better reflects true cost, using a national average drug acquisition cost as the cost, and then adding a professional fee that's true, or as close to true as we are today, to the actual overhead of a prescription. So the 1155 that was calculated is the average cost of dispensing across Minnesota pharmacies. So they gather all of our financial data and grind that out and say, okay, what does it cost for the pharmacy to produce this prescription and get it to the patient safely? And so that's different in every pharmacy. The level of staffing that I have at my pharmacy and the kind of high touch service that we provide, our cost of dispensing is probably closer to $14. But we're on the high end. Others are on the lower end that run a leaner staff, don't have as many opportunities to interact with patients with professional staff as we do. And so they bring that average to 1155 as of 2021 data. Well, it's middle of 2024 almost, and so that my guess is that number's about $1.25 behind where it really should be. But this is the best we can do, and based on how it's calculated, that's what we can do. Now, going forward, our hope would be that since we're on a biennium for budgeting, that we could get a survey done every 2 years and be a little closer to the bumper of, the vehicle that is the true dispensing fee, because a lot has changed in the last couple of years financially, and we're short and we're behind. And it's not, if we can't cover our costs, if the cost is at cost and the overhead is at a 4-year behind cost, we're below water. And so you can't continue to do business below water and try and fill in with all these other little nuances and gigs that we have to create so that we can fill in the financial potholes to continue to stay in business and serve people. And I'm telling you, in the rural areas, when these pharmacies go away, there's nobody else there. The clinic has probably gone. There's a nurse practitioner that comes through town once a week. I mean, and that's about it. So the pharmacist is the person that people can go to outside of transporting to an emergency room or whatever to get just like basic health care information. And so it's important to keep these pharmacies in these communities because once they're gone, they're gone. And people are traveling miles. I mean, and for us to have to ration, can we fill this prescription or not fill this prescription? That's craziness. That's absolute craziness. There was a pharmacist in my pharmacy yesterday from one of the major grocery chains, and they told me that, pretty much as of now, they're going to stop filling the weight loss drugs that everybody's, are the big hype now. Those prescriptions, we can't fill them at our pharmacy. It's a $125 loss every single time we fill it for a 1-month supply for one patient for one prescription. When 90% of our business is generic drugs and we're being reimbursed at $1, $2, you can't fill in that 125 financial pothole with that resource. So
Okay. Thank you, Mr. Hessian. Follow up, Representative Ryer, and then I'll have one other member on the list.
Thank you, Madam Chair. Representative Bahner, we're going in with another fixed rate, which will become obsolete, as over time, as fixed rates do. Did you consider indexing?
Representative Bahner.
For this year, we had not considered that, and I think that certainly also relates to our budget constraints. Certainly that is something worth investigating for the future, and how we might do that as new rate studies become available. I think it certainly makes good sense to have that conversation. Just we knew we were a little bit constrained this year.
All right, thank you. All right, Representative Keel.
Thank you, Madam Chair. Something in the conversation, I listened briefly to news this morning getting dressed, and I heard that we are cutting back on prescriptions now because they're just not available, that we're not even getting them. And I know where Ozempic goes in rural Minnesota. You're darn lucky if you find it, and you have to go looking for who's got it. And it's one thing if it's a weight loss drug, but it is also helpful to diabetics. And so then I've been known to try to find where I can actually access it. So my concern is not just the reimbursement, but the fact that we're not even is the larger problem. We're not even accessing the prescriptions that we need for our constituents.
Yeah. Yeah. Thank you, Representative Keel. Okay. I didn't hear a question in that, so was there one? Your point is well taken.
Right.
Yeah,
I would just he's confirming it by his nod.
Yeah.
So yeah.
All
It
right.
just is a little more than alarming, and then the cost, and then people can't afford it. So
Absolutely. Thank you. Okay, so with that, we will move to the amendment. So thank you, Mr. Hessian. Thank you very much. I'm going to move the A1 amendment. And so this is my amendment. And what this does, this relates not so much to the subject matter of this bill. I was explaining to Representative Schumacher beforehand that, because we're kind of coming down to the end here, sometimes when we have an omnibus bill, things appear in an omnibus bill that haven't been really talked about a lot. I'm trying to avoid doing that by bringing this here today because this is some language that I would like to carry in the bill. So I'm bringing it as an amendment so that we can have a little discussion about it. So as you all know, I have concerns about managed care, which are very well known and we've discussed. And we actually heard another aspect of that here this morning with the pharmacy bill that we've just been discussing, kind of the impact of managed care on pharmacies. This has a more narrow scope. It has to do with vertical integration. As you know, we allow in this state vertical integration, an insurance company owning providers. We haven't done anything to rein that in, ban it, regulate it more than anything else. But one concern that has been brought up over time has been whether those vertically integrated organizations can pay their own owned facilities and providers who work for them more than they pay others in their network. Can they discriminate against those who they don't own and pay higher rates to those that they do? And so this is some language that I have come up with to try to put the kibosh on that, that if you are reimbursing providers if you're an MCO and you're reimbursing providers in our public programs, that you cannot pay your own more than you pay the others in the network. So this has come up in particular in the past with regard to dental care, for example, where the evidence came out. Let me just back up and say, you all know that it's difficult for us to know what is being paid by the MCOs. This is considered proprietary. We do, of course, have the all-payer claims database now, which I know Representative Elkins has been great about reminding us about and working on to beef it up and make it more usable. But the bottom line is that these rates are proprietary to us, so we don't get to know exactly how much is paid. But information has come out in the past that rates were being paid, for example, to dentists who were in clinics owned by a certain vertically integrated company. So that's what this language is doing. And so I'm moving this as an amendment, and it would be my intention to put it into the omnibus bill. So happy to have some discussion on this. Is there any discussion? Representative Nadeau.
I'm always available for a discussion, Madam Chair. And thank you. I think this is an interesting concept. I'm not quite sure that I'm completely. I want to throw a couple of examples out. Like I wonder if we would be shooting ourselves in the foot or harming ourselves. These are models that have built a business model that focuses on particular populations. I'll use a FQHC for example. They have different reimbursement rates, and I'm not saying that they do or they should or even can pay dentists at a higher or lower rate. But I would submit that the business models are different, and if they can negotiate a rate lower from an outside provider, my question is, why would we not want them to have the ability to do that? I know that you framed it in that they're discriminating and paying lower, but it may be a business transaction that works for that population.
Well, thank you for that question, Representative Nadeau. First of all, the amendment is a managed care plan.
Yep.
So this is not an FQHC owning, paying for some service.
I understand.
This is just a managed care plan. And, part of the problem here is, this doesn't stop them from negotiating a lower rate. It just says you can't then go and pay your own people, more. So if you're squeezing providers, because this is, the managed care plans, they have a lot of financial weight, as we just heard with the pharmacies. These are big organizations. And we give them our money as a state, and we say, here, we trust you to go out and pay for the service. And we know that as legislators, we're not only concerned about the side of the patient getting the care. We certainly care about that, but we also have to be concerned about the whole system that's there to provide the care for the patient, as, for example, with the pharmacies.
Yeah.
So, you know, I mean, I guess that's a thought, but I think that's kind of I don't think that's what's happening here. I think it's a very different scenario than that. I think this is paying your own folks and getting a lot more advantage than, you know, and then squeezing the other ones because you're directing the money toward the ones that you own. And if they're going to be in our public programs, I don't think we should permit that.
Yeah. You know, I think about maybe the other part I thought about this is I was starting to think about the ACO model where there was, you know, where there was groups of providers, both from a social service standpoint, from a healthcare provision standpoint, that work together to ultimately improve health outcomes. You know, less ED visits, less time in an ICF, for example, whatever it was. And I'm not sure how many of the, you know, staff model plans are out there and if this has a huge impact or not. But I would also say that, you know, I don't know if this would inhibit innovation. I don't know if it would, I mean, if there are those organizations, and I know that you carved out a little bit for value-based purchasing, and maybe that would take care of the scenario that I'm talking about. But when all of a sudden you take a population and let's just say it's got, you know, 1,000 PMPM, and you work within your vertical network and say, we're gonna really try to improve health outcomes, and if we do, we're gonna pay these partners, you know, the savings. Would this bill prohibit something like that from occurring?
Well, Representative Nadeau, I don't think so. I think that's what the exceptions are here for, as you noted. You know, and this may not be perfect language, and certainly, you know, we're not at the finish line yet.
Yep.
So if you have suggestions for me, I would be more than happy to talk with you about them, because I do want this to work. But I think it's time that we make sure that we're not allowing. You know, we've seen the numbers about how well the insurance industry is doing right now compared to our providers, who are really struggling, many of them. Not all, but certainly many are, especially those who serve our public programs. And, you know, we just want to make sure that the money, the billions of dollars that we're spending are actually, you know, being distributed while we still have what I consider a very dysfunctional system of running our programs through MCOs for the most part, that we at least try to make it a little bit more functional.
Thank you.
Thank you. Any other discussion? All right, seeing none, all in favor of adoption of the A1, please say aye.
Aye.
Opposed? The motion prevails, and the amendment is adopted. And so, Representative Bahner, to your bill, final word on your bill as amended.
Thank you, Madam Chair. And as I stated before, you know, we realize that there is a much larger conversation here to be had about how we ensure the sustainability of our local pharmacies. And in places like Greater Minnesota, and in some cases in our urban core, the local pharmacist and that pharmacy is the best and only place to get care on a really easy basis for everything from vaccines to collecting your prescription. And these are folks who generally know their population. They know the folks who walk through the door. They have an incredible level of trust. So I think we really want to do as much as we can to preserve that within our communities and make sure that that continues into the future.
All right, thank you very much. So with that, House File 3902 as amended is laid over for possible inclusion. Very good. Okay, we will take up now House File 3902. Oh, I'm sorry, wait a minute. What? Sorry, wrong number. 3495. And this is Representative Fischer's bill, but we have Representative Frederick is here to, because Representative Fischer is out today, and so thank you very much for being here to present this bill, and which is very extensive. So hopefully we'll have some conversation about this. Anyway, Representative Frederick is the vice chair of the Human Services Policy Committee, correct? Which is where this bill is coming to us from. So since he's not on the committee, I will move that House File 3495 be laid over for possible inclusion. And there is an author's amendment, which I understand is the A8. Oh, and I should say that it is the first engrossment, right? Okay. So we've got House File 3494, the first engrossment. I'm 95, geez. Still trying to recover from last night. Okay, so the A8 is before us, and Representative Frederick, do you want to describe the A8, or would you just rather have me?
Doesn't matter.
Okay. So the A8, as everyone knows, the House File 3495 contains a lot of material. It's kind of the wish list, and we know we don't have the budget to take up, for example, expanding rates and so on this year. So the A8 is taking out a lot of those, the parts that we just aren't going to really be able to consider this year, that have been considered in the Human Services Committee, but we really can't entertain this year. And there's a lot more in here, though. I don't know if someone else wants to, or if we need to discuss in particular the other parts of this amendment. Representative Frederick, is there any more you want to say about it?
Thank you, Madam Chair. I would just briefly say that it does just take a lot out of the bill that has a financial cost. Just because it's, as you said, the bill has a lot of really, really good provisions in it. We just can't afford to do some of them. So I think that would be the simplest way to describe the amendment.
Okay. All right. So with that, any discussion to the amendment? We'll adopt it, and then we'll have a lot more discussion about the bill. So, all right. All in favor of adoption of the A8, please say aye. Aye. Opposed? Motion prevails. The A8 is adopted. So, Representative Frederick, to the bill as amended.
Thank you, Madam Chair and committee members. House File 3495 includes the highest priority recommendations presented within the Human Services Policy Committee to address Minnesota's mental health services access crisis by improving policy to reflect best practices in the field, decrease administrative burden, and prioritize client care. Excuse me. Our committee thoughtfully reviewed and developed a comprehensive look at children's mental health, adult mental health, substance use disorder, workforce needs, and related policy priorities. We worked closely with the Minnesota Department of Human Services and on their suggested technical assistance for the components of this bill. We also include a number of funding priorities to meet the greatest needs in the field. The delivery of the DHS rate study launched robust discussion around our Medicaid outpatient mental health rates as the very top priority to resolve the crisis in access to quality care. Due to our challenging spending target, as we just talked about, investment in rates most funding the priorities have been removed from the bill. I remain hopeful for future opportunities to stabilize our mental health field and deliver the care needed to resolve our mental health crisis. The bill, as amended, achieves important gains to support quality delivery of care. I want to highlight just some things that are in the bill, allowing assessments to be conducted based on a need instead of just saying everyone has to do assessments, letting the providers make some of those judgments on their own. Meeting fidelity standards for assertive community treatment teams, updating staffing requirements to enhance access to care while supporting staff to operate at the top of their licensure, supporting clinical trainees to serve clients until the point of licensure, benefiting sustained client care and preventing a gap in service, increasing access to respite care for families and supporting a child with mental illness. And there's even provisions in the substance use disorder space talking about how people who are successfully complete treatment often, or some have experienced times of homelessness and they may not have anything, including identification. And so this bill even says that we want to help them get a certified birth record because we know they need that then to establish housing and continuing on their recovery journey. So there's a lot of really good provisions in this bill, and I look forward to the discussion.
All right. Thank you, Representative Frederick. And members, there is a really good summary, comprehensive list here of bills that are included in this that we've been provided by our research staff. So, and that is to the bill as amended. So let's see. Do we have some testifiers? We do. So if we could get Kirsten Anderson, I think is first. Welcome to the committee.
Madam Chair, members of the committee, I'm Kirsten Anderson with Aspire Minnesota, a statewide association of child and family serving organization. Thank you, Chair and committee, for your leadership in advancing solutions to our unabated mental health crisis. The media in your packet demonstrates a lack of access to mental health care statewide and the clear solution to investing in Medicaid outpatient and inpatient rates to build access to care for Minnesotans. Without a rate solution, we are stuck in crisis response, with consequences felt by the children and adults who are forced to rely on hospital boarding, juvenile detention, and jail because they get sicker waiting weeks or months for care. We lament with you that a rate solution is not advancing due to the inadequate nature of your spending target. The 2023 HHS Omnibus passed in anticipation of fixing mental health rates this year and included a sunset of an outdated critical access enhanced rate. With the spending target affording no action on rates, the sunset creates a $25 million funding gap over 3 years for safety net providers. We implore consideration of a bridge for the loss of these resources by implementing future rate structure elements. For example, eliminating the 20% master's level cutback is one viable strategy.
Could you repeat that last thing you said? You said that so quickly I couldn't understand it.
The 20% master's level cutback.
Okay, thank you.
We know too well the heartbreak of the crisis. Increased need, decreased access, heightened acuity, crisis, self-harm, hopelessness. House File 3495 includes the Mental Health Legislative Network's best policy solutions to improve access to quality care, underscored by 3 hope-filled themes. We have the solutions to build the mental health continuum of the future. Accessing timely treatment makes a difference, and investment in Medicaid outpatient and inpatient rates is foundational. Key policy in House File 3495 includes helping kids attend day treatment with needed medication, modernizing supervision and medication management rules for children's residential, giving clinical leaders needed flexibilities for care delivery and intensive residential treatment services, FERTS, ACT teams, and CTSS, shortening timeframes to initiate care for children and families, streamlining SUD policy, and aiming to ease hospital boarding pressures. We remain grateful to your commitment to build the mental health continuum we desperately need. And we are in lockstep agreement that this target is an inadequate response to the mental health needs of Minnesotans and remain hopeful for the future. Thank you so much.
All right, thank you. Dr. Chawla? Welcome to the committee.
Thank you, Chair Liebling and committee members. My name is Dr. Gigi Chawla. I'm the Vice President and Chief of General Pediatrics at Children's Minnesota. And I have oversight over mental health services. I appreciate being here today to express our support for House File 3495. At Children's Minnesota, we provide a continuum of mental health services, including integrated behavioral health and primary care, outpatient mental health clinics, and partial hospitalization services, crisis stabilization, and acute inpatient mental health. Despite efforts to expand these services, we cannot meet the current demand, and children are waiting for months to access care. Parents often recognize their child's need for support early on, but have run into long wait lists and other barriers. While waiting, their child's mental health gets worse, and families find themselves desperately seeking a solution, which is what brings them to emergency departments. In 2023, 12,000 children statewide boarded in hospitals. Kids boarding at Children's Minnesota collectively spent more than 1,600 days stuck because the appropriate mental health treatment setting was not available to them. The bill before you would support these children by developing a medical assistance benefit for children's residential crisis stabilization and increasing funding for respite grants that directly support families. In addition to these vital services, investing in Medicaid mental health reimbursement rates is foundational to this work. Nearly half of our patients receiving mental health services rely on Medicaid, and currently rates for mental health care are reimbursed for less than half of our costs. As costs continue to rise, that level of reimbursement is getting worse. I understand that your committee target does not allow for the investments needed to address this issue. It doesn't stop me from talking about it. To meet the needs of the patients in our state, mental health care needs to continue to grow capacity and expand services, but in the face of unsustainable reimbursement rates, too many providers are finding themselves having to make tough and inhumane decisions about whether or not they can even continue to operate at their current level. We are grateful for the elements included in this bill, and I know they will make a difference, but we cannot make Minnesota families wait another year before doing what is foundational to addressing the crisis they are experiencing. Thank you.
All right, thank you for your testimony. Shannon Brown? And then Shannon Brown will be followed by Susan Fort and then Jody Brennan. Welcome back. Please state your name again for the record.
Shannon Brown. Madam Chair, members of the committee, thank you for the opportunity to testify in support of House File 3495. As I stated earlier, my name is Shannon Brown, and I'm the CEO of Fernbrook Family Center, and we provide mental health services across 9 counties in southeastern Minnesota. Over the last several years, you've heard countless testimonies about the mental health crisis and the new rate structure required to resolve this crisis. I would like to share with you today how House File 3495 will help providers manage workload and administrative burden during a very difficult time, and how continuing to find ways to be creative with rates will help us to build a sustainable and sufficient mental health system for Minnesotans. Let me first speak to a few policy items in this bill. Allowing CTSS family services to be billed while a child is in day treatment will provide the flexibility for us to provide wraparound care for children. While the child is in day treatment receiving services, learning how to regulate their emotions, communicate their needs, manage their anger, reduce aggressive behaviors, and build their skills to manage distress, the caregivers can receive family therapy to build the skills they need to support their child in doing these things outside of day treatment. Equipping caregivers during this available time will lead to more successful treatment outcomes for children. Another valuable policy change is the adjustment to functional assessments being completed annually for adult rehabilitative mental health services. Currently, these are completed twice a year, and clients become frustrated by repeating their story multiple times per year. Many clients have painful histories of violence, drug use, sexual assault, and suicide attempts. Forcing them to share these experiences multiple times a year prevents them from moving forward in treatment and causes paperwork burden for staff that is unnecessary. I also have serious concerns about the loss of $25 million in critical access funding with the phased termination of the enhanced rates over the next 3 years. Implementing the 20% master's level cutback proposed in the rates bill is one creative solution that can fill the gap and begin building a future rate structure. Our mental health systems are losing resources faster than we're creating them. A recent survey of providers found that 66% are shrinking their services, 38% have closed services altogether, and 22% are considering closing services within the next year. Until a new rate structure is established, we simply can't afford to lose funding for safety net providers because we can't afford to lose additional capacity to meet the growing mental health needs of Minnesotans. We must fund this gap. I recognize the difficult task before you, and I believe we can still work together to build a path forward, to build a path that creates sustainable mental health systems that continue to make a difference in the lives of Minnesotans for generations to come. Thank you for your leadership and support.
Thank you for your testimony. Susan Fort? Welcome to the committee.
Thank you, Madam Chair. First, I want to thank you guys for letting me come and share some of my experience using respite, how it's benefited my family, and the struggles that have come from the lack of ongoing available respite to our home.
Could I just ask you to just state your name for the record?
Sorry. Susan Fort.
Thank you.
I am a single parent home with 3 special needs children. One of these children is also medically complex. All of my children have varied degrees of autism spectrum disorder along with a multitude of other diagnoses. I have no support, no staff support, no family support. What happens in my house begins and ends with me and what I can provide for my children. I do all of the appointments, the therapies, the advocating, dealing with all of their behaviors, medical treatments, school meetings, transportation issues, and anything else that may pop up that specific day. So how did respite help my family? It gave me a break from being the primary and only caregiver. It gave me a few nights where I could really sleep. Sleep without needing to worry if the door alarms will go off from someone deciding to leave. Sleep without needing to worry about oxygen sensors or seizures. Sleep without worrying about someone getting up in the middle of the night and doing something around the house that may not be completely safe, like using the stove, trying to cook something, doing whatever project he decided to get in his head that night.
It gave me the ability to do something to fill my cup, something that often does not happen, to take a breath and do something for my mental health. It's been almost a year since I've been able to use any kind of respite for my kids. I am constantly hitting walls trying to find a provider. There are not many places to choose from to begin with. Some of the barriers I have ran into are not providing services to children outside a certain county, only offering respite on the first weekend of the month, and even so with that, usually that company is filled up for the whole year by the end of January. Offering respite only one Saturday a month, but it's only for 4 hours, and it would be an hour-and-a-half drive to get there. I've also experienced a provider just stop corresponding with myself and my kid's case manager. Just to paint a small picture and give you a moment, I want to share a small experience that's not an uncommon situation in my home. Keep in mind, you are the only provider. You're the only provider for your children. One has been sick, and so he's been having more seizures. This means round-the-clock monitoring of O2 stats and fevers. Your other child can't sleep and gets the idea that he wants to go to Target and look at Pokemon cards. It's only 3:10 in the morning. What could go wrong? Your third child has been having behaviors like headbanging and scratching himself because the routines in the house have had to change due to his brother being sick. This can go on for days at a time. You're exhausted, depleted, and feel completely overwhelmed by the knowledge that no one is coming. Literally no one is coming to relieve you. You're it. In days and weeks like this, I would cling on to the knowledge that in just a few more days or a few more weeks, my break is coming. My relief is there. Relief was in reach. I could see it. I could grab it. Not having respite for my family and families like mine increases the amount of stress we experience as the sole caregiver to our loved ones. These are just a few reasons that I am asking for the increased funding to put towards family respite for families who struggle like mine. Thank you for your time.
Thank you so much for taking time to come and testify here today. Really appreciate it. Thanks for sharing your story.
You're welcome.
Jody Brennan. Welcome to the committee.
Thank you very much, Chairwoman Liebling and committee members. I am Scott County Commissioner Jody Brennan. I'm speaking on behalf of Scott County, the Minnesota Inter-County Association, the Minnesota Association of Counties Social Services Agencies, and the Association of Minnesota Counties. The support of legislation that addresses children mental health healing continuum of care is a top 2024 Scott County legislation priority. While House File 3495 includes many crucial provisions to help as children and youth, I'm here today to encourage passage of the establishment of an MA benefit for residential crisis stabilization for children and youth. In 2022, legislation created a work group on children's stabilization external provider. That group has been meeting, and much of the work set out in Section 8 of the bill has already been addressed in this work group. And it is my understanding that there are currently providers who are committed to filling this need. I would also like to talk to you about a 15-year-old Scott County youth who had an extensive history of multiple placements and long history with children's mental health case management. She had complex and intense mental health needs. Upon completion of residential mental health treatment, she had been in foster care for 2 years. Even though this child received ongoing support from Scott County Case Management and from community providers, continued ongoing behavior disrupted the nearly 2 years of foster placement, and she entered into a juvenile shelter facility. At the juvenile shelter facility, her behavior challenges resulted in an altercation with another resident. She was charged and detained in a locked juvenile shelter facility and is now unnecessarily involved in the juvenile justice system. This story illuminates the serious gaps in the continuum of care for many youth in need of mental health and stabilization and crisis intervention. This is just a story about Scott County, but all Minnesota counties can tell you something different, can tell you something similar, I'm sorry. Stories like children utilizing hospital emergency departments to board children for extended period of times because there's no other placement opportunities. Access to appropriate placement options that are trauma-informed, such as crisis respite, is critical to the safety and well-being of these youth. Residential crisis stabilization for children and youth will provide a necessary and clinically appropriate response for these struggling children or their families. Since much of this work has been completed, we do respectfully request moving the timeline for DHS report to the legislation from October 1st, 2025 to January 1st, 2025. I appreciate the opportunity to speak to you today on this very critical issue. Thank you.
Thank you. Thank you for your testimony. Is there anyone else who wants to testify on this bill? Okay, not seeing that. And we are going to do a couple of amendments, but they have to do with other things. So we're going to, if there's, let's have discussion on this part of the bill right now. Representative New Brindley.
Thank you, Madam Chair. And I don't know if this question would be for Representative Frederick or maybe Mr. Harney. I'm just wondering if we can get an idea after the amendment what the cost of the bill is of what is remaining.
Madam Chair, Representative New Brindley. So the first engrossment certainly cost in the nature of $800 to $900 million. I would venture to guess, without a fiscal note completed, that the first engrossment as amended by the AA is substantially less than that. Approximately $10 million may be a good guess, but without a completed fiscal note, I have no way of confirming that amount for you.
And I would just add to that, Representative New Brindley, and for everyone here, that there's still a lot here, and there's no guarantee that we're going to just take this whole thing and plop it into an omnibus bill. So it's kind of a, we still have to figure out the budget. So Representative New Brindley.
Thank you, Madam Chair. And that was my next question. This might be for you. I don't know. My question is, obviously, with the committee structure, I know jurisdiction over funds is complicated right now. And so I'm wondering if you have any idea of the pieces of this bill. Would all of this be carried in the health bill, or is it possible that some of this funding would be carried in another bill?
So that's a great question, Representative New Brindley. No, this is here now because this is ours or nobody's. So that's the tough decisions we have to make, because as you know, we don't have an enormous budget. Representative New Brindley.
Thank you, Madam Chair, and I appreciate that. So what's left, I think, frankly, it's really important stuff, and I look over these things, the transport startup grants, the respite care services are left, the in-home children's mental health, I think those are very related to one another, right? I mean, helping families provide better care within their own homes, both through the in-home infrastructure grants and the respite services. So what's left is really critical. And frankly, what was taken out is really critical, right? And I will just reiterate that, one of the testifiers said that they know that the committee targets do not allow adequate funding. And frankly, we had an unaffordable, irresponsible $30 billion budget last year. And that is what means that we do not have adequate funding now to fund these essential services. These are essential services that I think everyone in the legislature, I don't think it's everyone in health, I don't think it's everyone in human services, I think everyone in the legislature understands the mental health crisis that we are in. And this did not just crop up this session that we're now suddenly trying to figure out how to deal with it. But that's the problem we have. There is not adequate funding, but there could have been. Thank you, Madam Chair.
So Representative New Brindley, I've listened to you make a version of that comment quite a few times recently, and I usually don't respond to it, but I kind of feel like I need to a little bit. First of all, there was a rate study that was going on last session, and clearly, if we had guessed at how that was going to turn out, we would have been very, very wrong. And obviously what it showed is that in medical assistance, we're not meeting the need. We are not meeting the need. You know, we recognize that. We did not have that last session. We didn't have the results of that study. We kind of did the best we could with the budget that we had in this committee. But, you know, I just think there's let me just put it as nicely as I can. You know, I hear sometimes the minority complaining about things that are inconsistent or making inconsistent complaints. On the one hand, I very clearly recall last session that what the minority was urging us to do was, quote unquote, give it all back. So it should have all gone back to the taxpayer. We didn't need to have any of that money. We should have just sent out checks and there it would have gone. On the other hand, the minority not having to put together the budget can complain about our not spending enough on anything that we do need to spend more money on. You know, I welcome your partnership on some of the things you've mentioned here. I think I absolutely want to have everyone's input on which are the most important things that will make the most difference with what we can afford. And, you know, I've been in the minority a few times and I've seen that it's hard for either side. When you have to put together the budget, you never meet all the needs. You always feel like there are people that you're disappointing and, more importantly, that you're leaving their needs, their critical needs, unmet. This is just part of our job, folks. This is the way it works because we never have enough money to meet all the needs. And so I appreciate that being in the minority sometimes allows people to spend the money over and over any way they would like at any given moment. But, you know, I do think that we need to inject a little reality here. You know, we are going to try to do our very best. We recognize that in the future, you know, we do need to meet more these needs. And, you know, and let's face it, you know, it isn't even only people who are in medical assistance. We, I'm sure, have plenty of people in the state who are maybe have a little bit higher income than that, a little higher income than Minnesota Care, and still do not get their needs met. So we have a ton of unmet need, not only in mental health, but across many, many different things. And, you know, we can't give it all back and meet all the needs. You know, we have to find a balance. That involves that dirty word taxes. And it involves, you know, trying to do our best to meet the needs of the state and create a balance. And that's what we're all here to do. And go ahead, Representative Newberg.
Thank you, Madam Chair. I would just point out that there was never a message out of our caucus to give it all back. Certainly, we believed that tax cuts for Minnesota families to make life more affordable should have been part of the deal. But frankly, this give it all back did not come from inside this building. That was from outside this building. But giving money back to Minnesota families would have been the right thing to do because Minnesota is more expensive and more difficult for the vast majority of Minnesota families right now, which frankly we see the ramifications of over and over and over in this committee. And when the majority party decided to spend $730 million to replace our office building, yeah, I've got a problem with that. That $730 million could go an awfully long way to solve the problems that we have in this committee. There's $250 million sitting over in Dolly in appropriations that haven't even been dispersed. You chose to give my family $2,000 a year. I don't need it. So we can say that somehow one party just wants to spend all the money and one party doesn't want to spend any of the money. It's just BS. It's just not true. It's just not true. Government should work for Minnesota families, and it is not. As we know, just from this committee hearing today and just from this bill, government is not working for Minnesota families. And while government is not working for Minnesota families, we are squandering billions of dollars on stuff that Minnesota families would say, I don't need it. I don't need it. And those are my tax dollars that you are using on, frankly, garbage. So let's have perspective on reality here.
All right, well, case in point. Let's move on here. So, okay. So let's go to the amendments. We have okay, so did you, Representative Bierman, did you want to offer the A6?
Thank you, Madam Chair. Yes, I would like to offer the A6 amendment, please.
Okay, so the A6 is before us. Representative Bierman, please describe the A6.
Thank you, Madam Chair. Members, this amendment will put a pause on the large numbers of closures of critical healthcare services in our hospital systems across the state. These closures impact the available care Minnesotans need. Closure means further distances to travel to access needed care. It means a loss of community services, including impacts on community employment, but most importantly, closures result in a decline in the overall health of Minnesotans. Local community health care is essential for well-being, and distance matters. Just recently, we have seen closures in clinical outpatient mental health services, inpatient adult mental health beds, pediatric inpatient beds, intensive care units, surgical services, SUD treatment, obstetric care, all essential services. Thousands of patients adversely affected, all tied to hundreds of full-time equivalent positions in local healthcare professions. Members, these are some of the medical conditions with statewide shortages of treatment already, and we are closing them. In communities across the state, where do people go? Farther from home, farther from family, even out of state to obtain medical treatment. Members, I read recently that Minnesota has lost 45% of rural maternity wards. Some people refer to these areas now as deserts, but that term is wrong. Deserts are naturally occurring phenomena with their own ecosystem, self-sustaining. Not having a clinic or a healthcare facility in an otherwise thriving community, that is policy. Decisions are made to take them away. Decisions around this table impact our healthcare system in a myriad of ways, as we all know. We can do better, and we should do better with that, and we all have a role to play. This past off-season, I toured a few hospitals in various parts of the state. Meeker County Litchfield Hospital impressed me. I asked about a birthing center, and they said yes, we had a tour of it. They have 96 births per year. That is not enough to cover the costs of keeping a labor and delivery unit open. But they assess their community health needs, and they maintain that service because they know the importance of the community, and that when you start to take away services, you lose people. We need more of that. How can communities take part in the decisions of their local hospitals to keep their medical facilities viable and open? The closure bill of Rep. Smith gives these communities an opportunity this year. Communities need more opportunities to participate in their healthcare assets. Now, I'd love to have a longer discussion, and I think we do have some people who want to weigh in on this amendment today, so if we can go ahead and do that, I would appreciate it. I do know, before we have this discussion, I know there are many people in here who know that the reason for closures are a myriad of issues. I know hospitals need a healthy balance sheet to keep their doors open. We all know that. I also know that it is about reimbursements, as we have heard from testifiers today. Dr. Chawla mentioned it, others have mentioned it. We all have heard this all session long. I also know that we in this country have plenty of money in our healthcare system. The problem is the money ends up in the wrong place. Our system is a poorly designed, complicated system. Nowhere in the world, I will remind you, is the model of the United States healthcare system emulated. Keep that in mind. We can do better. I know that is why all of you sign up for this committee, because you want to help make change to this healthcare system. We have plenty of work to do. I do want to hear the testimony and all members' comments. And I actually have a free afternoon if we want to continue and have more conversation about fixing our healthcare system. So I'm available. But I am going to withdraw this amendment at this time.
Well, not
But
if you want testimony.
I do want testimony.
All right, so don't withdraw it.
I won't withdraw it yet. But I do want to hear that testimony, and if we could do that next, Madam Chair, I'd appreciate it.
All right, very good. And Representative Frederick, if you want to come to the table and just sit with us and have a donut if you want while we're here, and we'll invite the testifiers to come down and speak on this, which I know isn't exactly the topic of your bill, so thank you. So I don't know who we have on the list here. Mr. Balio or somebody else? Welcome, come down. Welcome to the committee. Please state your name and tell us who you are, and go ahead.
Good morning, Madam Chair and committee members. My name is Jenny Block, and I'm a registered nurse who works at Mercy Hospital Unity Campus in Fridley in the ICU. I have been a nurse at Unity for 11 years now, with the last year being in the ICU. In February, Align announced the closure of the intensive care unit and surgical services at Unity, as well as its intent to close pediatric inpatient beds at Mercy Hospital in Coon Rapids. In a letter delivered to the Minnesota Nurses Association, Align executives stated their intent to lay off 63 registered nurses at Unity campus by June of this year as a result of these closures. As you can imagine, this has been a very anxious and stressful time for the nurses, doctors, nursing assistants, surgical techs, and other staff at Unity. It's difficult to understand these cuts with the growing needs of our patients and community. When I started at Unity back in 2013, it was a fully operational hospital with surgical patients being admitted at all hours of the night. Through my 11 years at Unity, I have seen many changes and the elimination of services impacting patient care. With these intended unit closures, we are putting our patients' lives at risk. As a nurse in the ICU, I know the care these patients require and deserve. From my experience on the COVID unit at Unity, I know what it's like to have a patient that requires a higher level of care and not have a place to send them to because there just aren't any beds available. We receive patients not only from our surrounding communities, but from other parts of the state, as we are often the only ones that have a bed available. Where are these patients going to go? When a patient takes a turn for the worse and they need more critical care, where are we going to send them? Alina plans to make the ICU into a step-down unit, increasing the number of patients a nurse can take while still requiring the nurses to manage critical drips and complex patient needs. If the patient becomes too critical, they plan for the patient to be transferred to another hospital. However, transportation out of Unity often takes many hours. Some of these patients don't have hours to wait. Are we really willing to risk our patients' lives waiting for transportation? Don't get me wrong, the nurses, doctors, and other healthcare workers are angry about these changes, but it ultimately is the patients that pay the price. It is our patients and community that deserve better, and I ask that you help stop these unit closures for them. Thank you.
Thank you for your testimony. Is there anyone else who wants to testify? Welcome to the committee.
Thank you, Madam Chairman and committee, for hearing us. My name is Kate Martin. I have been in healthcare for 23 years in various roles as a nursing assistant at St. Joseph's Hospital, a registered nurse in critical care at Mercy Hospital, and for the last 16 years, I've been a family nurse practitioner in Blaine, caring for children anywhere from 4 days old to geriatric patients up to 99. I am first going to read a letter written by Dr. Leisha Schweigert. She is a longstanding pediatrician out of Cambridge. And these are her words at this moment. Dear legislatures, I have been a pediatrician at Alina Health in Cambridge for 20 years. We stopped admitting children to Cambridge Medical Center a few years ago. Then, almost 2 years ago, Alina cut our labor, delivery, and nursery unit, telling our patients they are expected to travel to Mercy Hospital, which is up to 60 minutes away, even further if they are coming from north of Cambridge. This is not a safe environment for the community I serve. Now, the latest blow was announced in February. I cannot begin to describe my feelings about how Alina Health deciding to eliminate the pediatric hospitalist program at Mercy, which is planned for June. These amazing physicians take expert care of my and my colleagues' pediatric and newborn patients, since we are no longer allowed to care for them for ourselves locally.
We have no other place to have our pediatric patients hospitalized in the North Metro, short of sending them to Children's or the U of M. Unfortunately, these are even further away, and very importantly, they have had many instances of being completely full in the last few years. Mercy sometimes has to turn away pediatric patients too. Very few beds there are reserved exclusively for children. The remaining beds, other units, are in fact available to all ages, but in recent years, adults have been often prioritized. These pediatric hospitalists at Mercy also do countless ER consults, run pediatric and neonatal cold blue resuscitations, provide care to pediatric post-op patients for a variety of surgical specialties. The ER and surgeons will have great difficulty without them. Some surgeries may no longer be safe to do at Mercy. In addition, they do numerous consults with other pediatricians in the area, urgent care providers, and home health providers to assist in care plans and/or arrange direct admissions, efficiently avoiding the ER if possible. I am appalled that health systems have been allowed over the recent years to cut so many universally critical services. Healthcare deserts are widening, including in our own medically progressive state. Even metro suburban areas are tightening down on pediatric services so much that we risk not having enough beds available for even normal or typical RSV, rotavirus, flu, COVID seasons. Pediatric newborn and obstetric care should be valued and protected as a core service throughout our state, including at small but busy, vibrant community hospitals like hers in Cambridge. Now, even large community hospitals like Mercy are at risk. Clearly, these services are notoriously not always moneymakers for medical system. Nevertheless, these demographic groups cannot continue to be overlooked and medically overburdened on top of all other social and financial disadvantages they endure. In the past, large and even small hospitals found a way to provide these services by balancing them with services that were more financially lucrative. Hospital leaders were mostly physicians, and medical ethics guided their business decisions. This is no longer the case. Guardrails and support need to be put into place. Please take action. Sincerely, Lisa Schweigert, physician. I can tell you that I live in Champlin, so Mercy is the closest hospital to me. I am very comfortable bringing my children for basic healthcare needs up to Mercy or to even Unity. I can tell you from a practitioner standpoint that in the clinic, when I have a small infant that has RSV and is kind of borderline, and I go, gosh, I could send this kid home. They don't really need to go down to Children's, but I kind of want someone to keep an eye on them. I have the inpatient pediatric hospitalist's cell phone number. I can call them, I can run the case by them, and they go, send them up to 4 West. They don't have to go through the emergency room. They are monitored for the next 24 hours, made sure they have everything they need, and then they are sent home safely. I serve Blaine and north of Blaine community and families. We have a very broad socioeconomic status. I can tell you that the families in Cambridge or north are going to choose not to go all the way downtown, and therefore their children's lives will be at more risk. They have one-income families. They have one vehicle. They cannot miss work. I don't expect Mercy or Unity, and this isn't even just about Alina. This is North Memorial has closed their inpatient peds. Maple Grove no longer takes them either. Okay? It's a bigger deal. I'm sorry, I lost my train of thought. But this is important. It's an important service. I don't expect rural hospitals to take on what Children's takes on. I would never expect them to do thoracic surgery at Mercy. I would never expect them to do chemotherapy. But basic needs for kids need to be available for them and their families, because I worry families will not reach out if they have to drive an hour and a half. Thank you.
Thank you for your testimony. Is there anyone else who wants to testify on the amendment? Welcome to the committee.
Thank you, Madam Chair and committee. My name is Zach Heidebrink. I live in Isani, which is about 5 minutes, 10 minutes south of Cambridge. I'm telling the story today of my now 1-year-old son. Sorry if I get emotional. At the time was 5.5 months. It started on Wednesday, he's teething. We left it as teething. By Saturday, he had a runny nose. Friday night, Saturday morning, he was starting to get a little lethargic. Not quite where we wanted to bring him in because we figured it was teething. By Saturday afternoon, My son does not cuddle. He wants to be on the floor. He wants to play. By Saturday supper time, he was laying in my chest and wouldn't even pick his head off my chest. We decided we were going to wait till the next day, Sunday, to go to urgent care because we knew that Cambridge does not have a pediatrician, which is 10 minutes from us, care. We decided to go to Cambridge ER, which they monitored our son for 4 hours, and then they couldn't keep his oxygen above 90 on an adult 6-liter flow of oxygen. When we first got there, we had the option of driving him ourselves to Children's or taking an ambulance to Children's or Mercy. If we went to Children's, we'd have to go back through the ER, which who knows how long the wait is just to go through ER. Or we choose Mercy, which they have a bed available. By midnight, the doctor didn't give us an option of us driving him to either one. We chose Mercy for the bed. We wanted the bed right away. We didn't want to have to wait through ER. On transport went smoothly. We got to Mercy. They no more than got him in the room. And mind you, from Cambridge to Mercy is a half hour. From Mercy to Children's is at least another half hour with no traffic. So what happens when rush hour hits? It's another half hour on top of that. So you're talking an hour from Mercy just to Children's. An already full hospital. We chose the Mercy for the bed. We got to Mercy. He got to his room. He was in my wife's arms, and his head went back, and he was pale as a ghost. That's a half hour. If they had to put him on a high-flow oxygen machine at 10 liters, 50%. An ambulance doesn't have that machine. The Mercy saved my son that night, and if we would have had to go to Children's, he would have died in an ambulance. Last week, we celebrated his first birthday at her parents' house. If Mercy doesn't have these beds available to us in the northern region, I'm celebrating my son's first birthday at a cemetery last week instead of our home. It's the 1% that needs those beds. I get most cases don't need those beds, but we were the 1%. I hope to never be that 1% again, but that 1% is going to happen to the next family. It happens every day. There's a 1% that needs those beds, and which those beds are already taken up most of the time anyways. So when we get sent to Children's or anywhere else and have to go through ER again, there's no way that in a case like that, anybody coming from the North region has a fighting chance to survive. So I beg you to please, for the northern half, help us keep these beds open. Thank you.
All right, thank you so much. And you know what, sir, before you go, we didn't get your last name, which we kind of need for the record.
Zach Heidebrink, Heidebrink.
All right. Well, thank you so much for being here and for your story, really, and we're so glad that your child is okay.
Thank you, Madam Chair.
Okay, Representative Bierman, anything further? Or any discussion? We haven't, oh, I'm sorry, did we miss? Okay, is there any other discussion? Oh, we have another testifier. Oh, please come down, sorry. Two more.
Both of you. You can both sit.
You can both come to the table and, right.
I can share.
Yeah, okay, who's first?
Go ahead.
Okay, please go ahead and introduce yourself for the record.
Hi, my name is Annie Jukacki. I'm the Regional Coordinator for Doctors Council. I represent the doctors that are impacted by the recent closure at Mercy and Unity. I'm here today to read a statement from one of the pediatric doctors that couldn't be here today. He's actually working. So he is actually one of 6 that are actually being terminated. They are being laid off because of the closure at Mercy. It says, hello, my name is Dr. Robert Mills, and I am a pediatric hospitalist at Mercy Hospital. At Mercy, we provide inpatient care to the North Metro, as well as areas further away like Elk River and Cambridge. Due to hospitals closing inpatient pediatric services over the years, Mercy is currently the only hospital in the North Metro that has the ability to admit pediatric patients. Tragically, the inpatient pediatric services at Mercy Hospital is now being targeted for closure by Allina Health. Allina has indicated this decision was for financial reasons, but how does this serve the community? This is an especially important question when considering who will be negatively impacted the most. As history has shown, poor children and children of color who already face significant health disparities will be disproportionately affected. According to data from the Minnesota Department of Health, many of the communities we serve at Mercy have childhood poverty rates up to 20 to 40%. Oftentimes, these families that struggle with childcare needs, lack transportation, are unable to pay for expensive ambulance rides, and have other social stressors while their child is hospitalized and cannot easily be repositioned to the children's hospitals in Minneapolis and St. Paul. Where is the accountability for these hospitals that make these decisions without consideration of the repercussions to the larger community? Minnesota has been known for some of the worst health disparities in the nation. Many organizations and individuals have been working hard for years to reduce these disparities, and yet Allina's actions will create more barriers by moving healthcare access further away. Again, where is the accountability? We cannot continue to allow hospitals to take public money and then run away from their public duties when it suits their bottom line. This has to stop. Our communities, our children deserve better.
Thank you for your testimony. And ma'am, I'm not sure we got your name also. Can you just state your name again?
Annie Jakacki, Jakacki.
Okay, thank you so much.
Thank you.
Welcome to the committee.
Good morning, Madam Chair and committee members. My name is Joe Schindler, and I'm Vice President of Finance Policy at the Minnesota Hospital Association. And I want to thank Representative Bierman for the discussion and for ultimately pulling this bill from consideration. Given this language was just introduced as a bill yesterday, MHA is trying to understand its full impact. That said, we have significant concerns about what it could mean for several of our members across the state who have been working with the Minnesota Department of Health and have announced service line changes, and for hospitals who, over the course of this upcoming year, may find that they may need to make service changes as well, or even hospital closures. MHA recognizes that these changes are not always easy for the community, as we've heard today. These decisions are not taken lightly. They are usually made because of safety and quality concerns, a lack of needed healthcare specialists, and yes, sometimes it is due to the lack of sufficient reimbursement to maintain that service line. MHA has been working with committee member Representative Smith on a bill that he is authoring, which adds more requirements and public transparency for certain service line changes or hospital closing. That bill is far different than prohibiting any changes for a full year in service line offerings. We are in a very dynamic and difficult healthcare delivery environment. What you are seeing now with service line changes or closures are the results of numerous financing and workforce challenges that the MHA and our members have been raising for several years now, and they're coming to fruition. Hospitals must be allowed to remain flexible to address access to care, help alleviate boarding issues, and ensure hospitals are equipped to support the care needs of patients into the future. Thank you very much.
Thank you for your testimony. Discussion? Oh, I should just, sorry, before I go there, let me not make the same mistake again. Is there anyone else who wants to testify? Okay. All right. Well, I will just like to make a statement, and that is that, as Mr. Schindler pointed out, we're not moving this bill this session. However, I think with what we're trying to make a statement about here, what Representative Bierman and others are trying to make a statement that, that hospitals obviously are a unique kind of business, and there's a very deep, important public interest in making sure that we have hospital facilities where they're needed. And it is very distressing to many people, obviously, to see these services going away and to see these closures because these things are not being replaced. And so when I think we are aware that there's a lot of complexity to this, certainly. And that is why, this is not something that's moving forward right now, although obviously the need is very great. And I guess what I would say, in response to Mr. Schindler, to the Hospital Association, is that I think hospitals need to understand that we, the public, really demand to understand better what is going on, and that we will not really sit idly by and just see the system fall apart. Also understanding that the public and that the state has a role to play. Obviously, there's complex financing that goes into this, but there is just such a deep public interest in this that I think we need your partnership to try to figure this out, because it is just not acceptable to be losing important services so that people in Minnesota are just left high and dry. It is just simply not acceptable. So there is a lot more work to be done. Representative Bierman.
Is this closing then? Or?
Yeah, I think, well, I don't see any. Oh, I'm sorry. Representative Nadeau, please.
Thank you, Representative Bierman. And thanks for withdrawing this. And I'm gonna try to keep my comments short and concise. And and I recognize the challenges. And I appreciate you spending time going and visiting the hospitals. I think I should introduce a bill next year that requires everybody on the health committee to spend 12 hours a quarter in a hospital working, with administrators and nurses and doctors and observing, because what goes on there is massive. And what we heard with these testifiers today, it's not one thing. A bill that prohibits closing a hospital. I mean, they're a business unit. They struggle. We in this committee are pushing more and more people into public programs that reimburse at rates that don't come close to covering the costs. Pretty soon our commercial payers are going to start saying, or people are going to say, wait, why am I paying, 200% of the cost, to make this up? We have a system that we've complicated. Not you and I, we didn't complicate this, but it's been complicated, and Madam Chair, you didn't either, by the way. But it's gotten complicated because we've tried to twist and warp and try to carve out this and protect that. And you may say that no one in the world, emulates, our healthcare system. But there's more people in this world that come here for care than any other country in the world, and especially Minnesota. As convoluted as it is innovative. It is expensive. There's, look at the drug rebates that come back to the state. $636 million are carved right off of the top that the state takes, and it goes to MA, which is fine, But those are the things that we should start looking at and working together, which I know you are willing to do. I am willing to do, rather than having a bill that says, we're gonna prohibit this. Maybe we should amend this. I mean, we're forcing hospitals today to do far more than they're capable of doing. I mean, it used to be a place where you would be able to take somebody and they would be treated and they would be stabilized and then they would go someplace else. Our system, there's no place else for them to go. I mean, we're now requiring our hospitals to be behavioral health, clinics and mental health institutions and ICUs and CCUs, and we house people in there because because of guardian issues, civil commitments. I mean, we are making our hospitals do massively more than what they're intended to do. They're not built for this. This is not supportive housing for, people with mental health issues. But that's what they've become in many, many cases. And you know this, we all know this. And hopefully maybe this bill is going to spur us to put our heads together and put our shoulders together and work harder to focus on those things that we know are going to, well, maybe we don't know, but we're going to try and be super flexible about listening to others and bringing those pieces together as much as possible. Anyway, so those are my thoughts. I'm glad that you're withdrawing it. I spoke longer than I planned to, and I apologize, Madam Chair, but thank you.
Thank you, Representative Nadeau. Representative Bierman.
All right. Thank you for the comments, Representative Nadeau. And I want to thank all the people that came out and testified today, because I think hearing from you really brings home to many members to hear those stories in depth, in detail, and to give it more of a human face. So thank you for making the trip in and testifying before us today. A lot of things, I could bring up and talk about, but I think one of the essential things is just to get people to think about the fact, we have something called network adequacy that we're always focused on as far as making sure that there are providers out there. And I think we are in danger of not having network adequacy when we move care further and further away from where people need it. And so this really has to be a focus. I have talked about that report called Poorer Health, Shorter Lives, which impacts Americans. And it really goes into great detail about discussing how much money we have in our healthcare system, how much we as individuals put out for the healthcare we need, and yet we're not getting the results of other countries. That's why I bring up other countries, because we can look at other countries, not necessarily for the model, but to get those ideas that are working there for better health outcomes, which I know everybody in this room has as the ultimate goal. So we do need to focus on where those funds are going and how they are supporting or not supporting our healthcare system at large, and that's what we need to focus on. So this is just something that will be something we can continue those discussions on. I welcome discussions from all sides, and we do have to do this together. So I thank everybody who has signed up for this committee, not once, but twice, 3 times. Some of you have been here a very long time and put in a lot of work to healthcare in Minnesota, and it is one of the better states in the country. But there are, again, those disparities. And so when we're looking at trying to create better outcomes for a whole population, we need, as a country, to decide what kind of healthcare system we want to have. Is it one that benefits all people, or is it going to be the continuation of a staggered system that some people get healthcare and some people do not? So thanks for listening. Thanks for entertaining the amendment. And we'll continue to work on it. Thank you.
All right, and I assume you're withdrawing the amendment now, Representative Bierman.
Do that now.
Okay, yes, thank you.
Withdrawn, please.
Thank you. Okay, thank you for that. All right, and so now we also now have the A7, which is actually kind of on the theme, and that's my amendment. So the A7 amendment comes out of my having served as a member on the governor's task force for the U of M academic health. And you may remember that last session sometime the University of Minnesota was floating the idea that they needed to build a new hospital and needed perhaps $1 billion from the state. And, it was quite clear that we weren't going to just drop $1 billion and say, here, go and build a new hospital. And probably $1 billion, quite frankly, wouldn't even build a new hospital. But one of the recommendations that came out of the task force was to have some kind of a needs assessment for the state even, but certainly for the metro area in terms of if there are going to be new facilities built, and it does seem really, quite compelling. The university clearly has some needs. I think other hospitals in the metro area clearly have some needs. That before we, or quite soon now, as we embark upon this bigger project, that we need to have an assessment of where we're at with facilities in Minnesota to kind of give us a bit of a roadmap of what we need going forward, how perhaps different institutions can collaborate and maybe share facilities. Maybe we don't need to duplicate a certain kind of laboratory across different institutions, that kind of thing. So, what this amendment does is it just kind of starts us at the very beginning of that process. It asks the Department of Health to put out a request for information to start the process of building a request for proposals. So it seems pretty clear that we'll need to hire, as a state, we'll need to hire a vendor, perhaps a national level vendor, to do the kind of assessment that we need. I don't know, as I sit here, all of the, exactly what would go into that. And that's why we're starting with an RFI. And the Department of Health has said that they have the ability to manage this process. It'll take a little bit of funding to start that process, but I think this is a really healthy thing to do because, we've all talked here today both about the deep public interest in making sure we have facilities where we need them. We need to be looking to the future, how healthcare is changing. There was some reference to like how long people stay in hospitals and, all of that kind of issue. So we need to look at capacity, future needs, where the assets are, who might be doing what, and really bring some objective information to this whole process that'll allow us, when we get to that point, to make wise public investments and to have them hopefully be in coordination with private investments as well, to help give a roadmap to the state for where we're going to go on facilities in particular, but also workforce, training, all of these things. It's a very big project. It could be, and I'm sure it'll need to be narrowed in scope as we go along. But this is just getting it started. So that's what this amendment does, and I didn't have any testifiers on it. I don't know if there's anyone in the room who wants to testify on this amendment, but if you do, please step forward. So not seeing anyone, and I have also shared this with HCMC. I've shared it with the U, and everybody seems to be, and of course this can change a little as we move along here, but people seem to be at least generally okay with this as a start. So any discussion? Representative New Brindley.
Thank you, Madam Chair. I actually think this is an interesting approach to start with a request for information to even build what we would want to see in a study. I think often we ask for a study without really knowing what we're asking for. So I actually think this is an interesting approach. I wonder if there's anyone from MDH who can let us know. I would be interested to know, obviously MDH is not DHS. In DHS we see tons and tons of unfulfilled FTEs that we appropriate. And I would be interested to know, is there a number of FTEs that we have already appropriated money for with DHS that would allow them to actually absorb the cost? Because I would assume that based on what we're asking for, I'm assuming this number is going to come in relatively low. So it would be interesting to know what might be available at DHS if they've got some unfulfilled FTEs that could actually absorb this. Thank you, Madam Chair.
Right. I don't know if you said DHS, but it's MDH.
Oh, sorry.
Okay.
I was talking about both, but I meant
Yeah,
MDH.
sure.
Thank you.
We all do that all the time. So Ms. Timian, if you can come down. Yeah, thank you for being here and hanging out with us today. Welcome to the committee. Please introduce yourself.
Madam Chair, members of the committee, for the record, I'm Lisa Timian, and I direct Government Relations at MDH, and there's nothing better than a beautiful spring day than being in here.
In the basement.
In the basement.
With no window.
On a Friday. Representative New Brunley, to your question, we have been doing some thinking about what would be what would entail with like an RFI. Learning a lot actually from the process that we did last year with this public options study, just in thinking like how it could be structured and what kind of information we need. Fortunately, we would not have the ability to use other expenses, or we don't have like a money pot that we'd be able to use for this. So it would come in probably with some small amount of cost, but don't think it would be huge, and we'd be thinking about scoping and what the committee and the legislature would be interested in learning about through this process.
Yeah. Representative Brindley.
Thank you, Madam Chair, and thank you, Ms. Timian. Do you know how many unfulfilled FTEs there are that have been appropriated for at MDH?
Ms. Timian.
Madam Chair, members of the committee, I do not have that, but I believe we can get that to you. I know that we have been doing a lot of hiring. We have a great HR team at MDH. And a lot of people are excited to work in fulfilling the mission to protect, maintain, and improve the health of all Minnesotans.
Okay.
Thank you.
Representative New Brindley. She's a master.
Thank you, Madam Chair. I would be interested in knowing that. I think that would be important information for the committee to have, knowing if there are a significant number of unfulfilled FTEs already we should have that information as we make these decisions moving forward. Thank you, Madam Chair.
Thank you, Ms. Timian. If you could provide that to the committee, we'll get out
Yeah,
out
I
to
believe
all the
we've
members. That would be great.
Work on some requests so we can get that to you, Madam Chair.
All right. Representative Ryer and then Nadeau.
Thank you, Madam Chair. Thank you, Ms. Timian. I just have a question about where the costs would go, because I believe that Chair Liebling mentioned engaging an external firm. So would most of the costs be FTE within the agency, or would most of it be an outsource?
Madam Chair, Representative Ryer, I'd have to look again about exactly where we're at right now in the thought process, but my understanding is it really would be engaging with an external group or organization to really start understanding this and what we would do, and rather than having all of the work for this happen internally.
Representative Ryer, follow? You're good? Okay. Representative Nadeau?
Thank you, Madam Chair. I just wanted to say I think it's a great idea. I mean, and hopefully we can find some funding to look at this. I mean, this is really what we were just talking about with, Representative Bierman is finding those ways and understanding that baseline of what it is that we do. And we have an old system that's been cobbled together. And what could the future of healthcare look like? I'm excited by that concept. So thank you.
Well, good. Well, thank you for that, Representative Nadeau. I appreciate that. Okay, any other discussion on this amendment? Okay, seeing none, all in favor of adoption of the A7, please say aye. Aye. Opposed? Motion prevails. The amendment is adopted. Wow, that was a unanimous one. I'm excited. Okay, so we are back on the House File 3495 as amended. And Representative Frederick, thank you for hanging out with us for all of that digression. Anything final that you want to say on your bill?
Not really, Madam Chair. There's a lot that we identified, even just during the discussion, that needs to happen, and I hope the work will continue, and I appreciate the committee's time this morning, morning.
All right. Well, thank you so much. So I just want to recognize all of the work that's been done by Representative Fischer, who wasn't able to be here today, by you and your committee, and Nick, the CA for the committee, and all of the staff on this, because this is quite a heavy lift, and really appreciate you being here to present it for us today. So with that, House File 3495 as amended is laid over. And we will be posting our budget early next week. And then, I don't think we've exactly laid out the process, but, this whole next week will be the process of processing the omnibus bill. We haven't set a deadline yet for amendments. I think we'll do that, and we'll have a day for walkthrough and testimony, and then we'll do markup. Markup will be Thursday, though, so just so we have the roadmap for the week. Anything else, any questions or concerns before we adjourn here today? So thank you, everybody, for coming in for this extra meeting, and enjoy the rest of your weekend. We are adjourned.